Thanks, Dr. Mohammed, for your introduction. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the Global Health Academy for inviting me to this excellent meeting. And it's my pleasure to share this session with my consultant, Dr. Metastatic Al-Fahedi, and to discuss the recent advances in management of breast cancer in general. In my talk, I'll be focusing on the hormone receptor positive, HER2 negative advanced breast cancer. The objective of my presentations, I have 5 objectives. In the first part of my presentation, I will highlight the recent updates of using CDK4 and 6 inhibitors in luminal type of breast cancer. Then I will review in the second part the recent data that we got after the approval of the first big 3 CAA inhibitor in breast cancer, which is alpelisib. Then I will discuss in details the toxicities management associated with this new agent. And at the end of my presentation, I will highlight quickly the NCCN guidelines to 2024 hormone-positive, HER2-negative breast cancer. This is my disclosure. I have nothing to disclose with regard to my presentation today. And this slide is just to show you the prevalence of breast cancer in Saudi Arabia. According to the cancer incidence report that was published in July 2019, they reported around 2,240 cases in 2016, and with the median age of those patients of 50 years. I don't know if Dr. Metastatic has a recent updates, but this is what we got officially from the Saudi Health Council. Fortunately, small percentage of those patients will present with distant metastasis, breast cancer, and majority of patients will be either having localized or regional disease. And according to the molecular subtypes, as we know that we have 4 main molecular subtypes, which are the luminal types, 2 types, and the luminal A and B, with a difference in the Ki-67 results. And the third type is known as triple negative or basal type of breast cancer. And the last type is HER2 positive disease. As you can see in this pie chart, majority of patients will be having the luminal type or hormone positive HER2 negative disease. So after diagnosing patients or having patients with advanced or metastatic breast cancer, physicians usually have to balance both the quality and the quantity of the life of their patients in metastatic setting, and they have to balance the toxicities from the agents approved in metastatic setting with the number of the years that those patients will live. So it's very important to think about the improvement of overall survival and to delay the disease progression of those patients. Besides that, you have to think about maintaining the quality of life for those patients. And the ultimate goal for management of advanced breast cancer is to transform this disease with the new agents, with new medications, from being a highly aggressive disease with high mortality rate to a chronic kind of diseases. Again, this is an algorithm for guiding physicians to manage advanced breast cancer patients. Again, they have to consider multiple factors in managing those patients. First is the histological or histopathological subtypes, the estrogen and progesterone receptor status with HER2 status. The second factor is the comorbidities for those patients, especially those patients may be elderly patients and they have wide range of comorbidities. And the third factor is to consider the patient's preference for choosing their treatment option. By collecting these factors, we reach to the final conclusion and individualize the selected options according to patient conditions. This chart is just to show you the timeline for therapeutic options in hormone-positive HER2 negative. We started with tamoxifen back in 1970s. After tamoxifen, we know that aromatase inhibitors were introduced to the market in 90s. After that, we waited for another 10 years to get the other molecule, which was fulvestrant. Fulvestrant or Faslodex was initially studied with lower doses with good outcomes, but when they they used the higher dose in the last, in 2010, they start using the high dose of Faslodex with excellent outcomes. And in the last couple of years, in the last 5 years, we received the approvals for new class of medications, which were the CDK4 and 6 inhibitors. And more recently, alpelisib or BIC3 inhibitor was introduced and granted the FDA approval in 2019. So now in the second part of my presentation, I will present to you the updated follow-up or the extended follow-up from the clinical trials that led to approval of the 3 known CDK4 and 6 inhibitor. The first trial was PALOMA-2. I think most of the audience are familiar with these trials, so I will just scan them quickly and present to you the updates. So in PALOMA-2 trial, they compared letrozole plus palbociclib versus letrozole with the hazard ratio in 666 patients with hazard ratio of 0.58. So the updated results showed that palbociclib with letrozole improved the progression-free survival with almost 12 or 13 months gain in the progression-free survival and risk reduction of almost 40%. Same for MONALEESA-2 and MONARCH-3 trial. MONALEESA, they studied ribociclib with, again, similar PFS outcomes, as well as in the MONARCH-3 trial. All of these trials were associated with excellent outcomes in the first-line settings. And after the release of the updated results, this confirmed the previous reports that CDK4 and 6 inhibitors are considered the first-line treatment for advanced breast cancer with hormone-positive HER2-negative disease. In the second-line settings, again, PALOMA-3, MONARCH-2, and MONALEESA-3 were updated, and these trials showed, again, significant improvement in progression-free survival. The first 2 trials, in PALOMA-3 and MONARCH-3 trial, the progression-free survival was a bit different because in PALOMA-3, they included patients with, we can consider them heavily pretreated patients with more endocrine-resistant breast cancer, and the chemotherapy was allowed in PALOMA-3. That's why we see the difference here between the 2 trials in terms of progression-free survival. In the MONALEESA-3 trial, they included patients with both first and second line treatment. So fulvestrant with ribociclib were used in both first and in the second line settings. And the PFS again was significantly better with the combination. So this slide is just to show you the difference between the first line and the second line inclusion of patients in MONALEESA-3 trial. As you can see here in the left side, ribociclib with fulvestrant associated with better progression-free survival, and there was a difference of almost 12 or 13 months in the first-line hormone-sensitive breast cancer. And on the right side, as you can see here, those patients are considered refractory or resistant to hormonal treatment. So they achieved good progression-free survival, but for sure it was less than the hormone-sensitive patients. The other clinical trial, which was MONARCH trial, in MONARCH trial, the conclusion of this study was that abemaciclib is very effective as a single agent in patients, heavily pretreated patients. So if you have a patient, elderly patients with comorbidity who cannot tolerate the fulvestrant or the fulvestrant, the second line settings, you can give a trial of abemaciclib with a dose of 200 milligrams once daily until disease progression. The conclusion of MONARCH-1 showed that this agent improved the overall response rate as well as PFS and overall survival. So the question that arose like a couple of years ago is the use of CDK4 and 6 inhibitor in premenopausal patients. So as we know that majority of patients here in Saudi Arabia are young patients, and most of them are premenopause patients. So there was like only one trial, which was MONALEESA-7. MONALEESA-7 was exclusively studied patients with premenopausal status. So the ribociclib with either tamoxifen or the aromatase inhibitors compared to the tamoxifen or aromatase inhibitor alone. And this trial, MONALEESA-7 showed significant improvement in both progression-free survival as well as the overall survival. So they included around 672 patients. So the question arises after this study, what about palbociclib and abemaciclib in the same setting in premenopausal patients? As you can see here in the PALOMA-3 trial, they included around 100 patients in the second line setting. They were premenopausal women. And in the MONARCH trial, they included almost 115 patients with premenopausal status. As you can see in the Kaplan-Meier here, almost we have similar effects. So the conclusion of these three trials is that all CDK4 and 6 inhibitors are showing good activity and very effective in patients with premenopausal condition. And in my presentation, I will mention this in the last couple of slides. I will discuss the NCCN guideline recommendation with regard to premenopausal women. The other important question that was raised was the role of CDK4 and 6 inhibitors in improving the overall survival of those patients. And to answer these questions, I will discuss with you the recent updates of the survival advantages of the three CDK4 and 6 inhibitors. So in MONALEESA-3, as I mentioned before, MONALEESA-3, they studied ribociclib with fulvestrant in the second line setting. The combination showed a relative risk of death in almost 28 patients, 28% of the patients with hazard ratio of 30%, with hazard ratio 0.724. The median progression-free, the median survival rate here was almost 13 to 14 months. In MONARCH trial, the overall survival was seen also with abemaciclib in combination with fulvestrant with almost 9.5 months, as you can see here in the Kaplan-Meier separation. The third trial, and the question was raised about the use of palbociclib without evidence of survival advantage. So as you can see here in PALOMA-3 trial, the outcomes, as you can see here in the hazard ratio was 0.81, and this was not representing a survival advantage in the entire cohort of patients. But if we focus on the endocrine sensitive patients, which were representing 410 patients, a survival advantage was seen, and the risk of the reduction of death was in almost 28% of the patients. So before I jump to the PIK3 inhibitor and the role of PIK3 post CDK4 and 6 inhibitors, I want to discuss one of the recent trials that was presented in last ESMO 2 months ago, which was the FLIPPER study or FLIPPER clinical trial. In FLIPPER clinical trial, it was a randomized double-blind phase 2 clinical trial. They studied the role of, or they assessed the role of palbociclib with fulvestrant in the first line setting. As we know that we have only MONALEESA-3 trials which tested the use of ribociclib with fulvestrant in the first line setting with major benefits in progression and overall survival. So this study was the first study to test the role of palbociclib with fulvestrant in the first line settings. They randomized patients to 2 arms, and the primary outcome was the progression-free survival at 1 year. And as you can see here in the Kaplan-Meier curve, after 1 year, the cutoff was for the first interim analysis was 1 year. So as we can see here, the patients stay alive. Stay alive without disease progression. Around 84% of patients achieve this outcome versus 72%. And the result of the first interim analysis showed that palbociclib with fulvestrant achieved the primary endpoint with the cutoff margin. This is the secondary outcomes in this clinical trial. Palbociclib with fulvestrant showed the progression-free survival benefits, and the progression-free survival was almost 32 months compared to 22. And this is very similar to what has been reported in MONALEESA-3 clinical trial. So what is the conclusion and summary of this recent updates of CDK4/6 inhibitors? So the conclusion is that CDK4/6 inhibitors are very effective type of medications in advanced breast cancer, hormone positive HER2 negative disease. CDK4/6 inhibitors granted the FDA approval in both first line and the second line settings in combination initially with aromatase inhibitors. And based on the recent studies from the data that we got from FLIPPR trial and the MONALEESA-3 extrapolation, CDK4/6 inhibitor can be combined with fulvestrant in the first line setting. So the question after that, what is the option after the CDK4/6 inhibitor in case of the resistance? We know that majority of breast cancer patients will develop a kind of resistance for the CDK4/6 inhibitors. There are like a mechanism for developing of these resistance. The first explanation for CDK4/6 inhibitor resistance is the loss of retinoblastoma gene. As we know that retinoblastoma gene is very well known as a tumor suppressor gene. Loss of this gene will lead to activation of the transcription factor, which is known as E2F. E2F will facilitate the progression and the cell cycle continuation of the proliferation and cell cycle divisions. The other explanation for CDK4/6 inhibitors resistance is the upregulation or increase in the cyclin D expression, which is known to cause acquired resistance to palbociclib in the PALOMA clinical trial. And the most important mechanism of resistance for CDK4/6 inhibitors that was found was the upregulation of the B3K/AKT motor pathway, which is resulted from the chronic exposures to CDK4/6 inhibitors. So moving to the second part of my presentation, which is the role of PIK3CA inhibitors in advanced breast cancer. As you can see here in this graph, we know that the PIK3/AKT motor pathways are very well-known targets for many medications. The growth factor usually started from the outside part of the cells, stimulating the external part of the tyrosine kinase receptors. Signaling these two parts will lead to activation of phosphorylation of tyrosine kinase, the internal part. The dimerization of phosphorylation will attract the BI3K or PIK3 to stimulate the whole pathway and eventually stimulating mTOR pathway. And the mTOR stimulation will facilitate and overexpression of mTOR pathway will stimulate further the transcription factor, which is known as 56K1 and 4-APP. The stimulation of those transcription factor will lead to further cell division and prevent the apoptosis and stimulate the process of angiogenesis. The PIK3CA pathway is expressed in almost 40% of breast cancer patients. There are 4 catalytic isoforms of PIK3CA. The most important one for the patients with breast cancer is the PIK3CA, which represents a target for the newly approved medication, which is alpelisib. So alpelisib is very specific molecules targeting the PIK3 alpha isoform. Alpelisib demonstrated a anti-tumor activity in preclinical models with PIK3CA mutations. And after the preclinical studies, they conducted a phase 1 and phase 2 clinical trials and showed a progression-free survival advantage of alpelisib when they combined with fulvestrant and the BFS was almost 9 months in patients with a mutant type of PIK3CA. After this phase 1 trial, the researcher conducted another phase 3 randomized controlled trial, which is known as SOLAR trial. In SOLAR 1 trial, they included patients with advanced hormone positive, HER2 negative, or recurrent breast cancer. Those patients were stratified according to the liver and lung metastasis to either and according to the previous exposure of CDK4 and 6 inhibitor, but unfortunately they included very small percentage of patients who received a CDK4 and 6 inhibitor. So in SOLAR trial, they stratified patients to alpelisib versus alpelisib with fulvestrant versus fulvestrant alone. And this is the baseline characteristics. What's really important to us here is the pre-exposure to CDK4 and 6 inhibitors, which was very small percentage of patients. In SOLAR trial, the outcomes was seen, there was a major improvement in progression-free survival with a hazard ratio of 45%. The progression-free survival was 11 months with alpelisib plus fulvestrant versus 5 months. So as you can see, Kaplan-Meier, it's separated from the beginning, and the PFS was doubled with the new agents. Muhammad, they received the notification. How many minutes, how much time I have?
So you still have more time. You still have around 12 minutes.
Excellent, because they received the notification. Anyhow, so with regard to the secondary outcomes of SOLAR 1 trial, the objective response rate was doubled in the total cohort of patients, and patients with measurable disease with liver metastasis and lung metastasis. As you can see on the right side here, the overall response rate was again more than doubled. Moving to the safety profile, which is really important for this medication, alpelisib is known as PIK3, and PIK3 has almost similar safety profile to mTOR pathway, because as I show you on the previous scheme of the PIK3 AKT pathway, we know that prevention of either AKT or prevention of or blocking of PIK3 will have the same effect or similar kind of effect, adverse effects of mTOR pathway. So in SOLAR 1 trial, the safety profile of alpelisib was not that great. Around 30% of the patients developed hyperglycemia, and the grade 3 hyperglycemia were around 32% with alpelisib, and the skin rash developed in almost 10% of the patients. So the most common side effects I can see is the hyperglycemia and skin rashes, as well as some patients may develop like kind of diarrhea. So the conclusion from this landmark trial is that treatment patients with alpelisib along with fulvestrant will prolong progression-free survival among patients with PIK3CA mutant, HER2 positive and HER2 negative advanced breast cancer. This is another interesting findings from SOLAR 1, which was presented in the virtual meeting of ESMO last September. They discussed the overall survival outcomes from SOLAR 1. And as we can see here in the results section, the alpelisib improved the overall survival, but this was not associated with statistical significant difference based on the pre-specified boundary. But according to the primary investigator of this clinical trial, they concluded that the use of alpelisib associated with clinical benefit, regardless the overall survival number, and the overall survival number was almost 8 months in the whole group of patients, but when they did the subgroup analysis for patients with lung and liver metastasis, the overall survival reached up to 14 months. So as I discussed before, that in SOLAR 1, unfortunately, they included only few percentage of patients with previous exposure to CDK4 and 6 inhibitors. So the question was, what about those patients who progressed on CDK4/6 inhibitors. And to answer this question, they conducted a study called BELIEF study or BELIEF study, which was presented in the last ASCO. It was a phase 2 non-comparative international open-label multi-cohort clinical trial. In my presentation, I will present only the current analysis about the use of alpelisib with fulvestrant with the previous exposure of CDK4/6 inhibitor. The primary outcomes of BELIEF study was the progression-free survival at 6 months, and the secondary outcomes were the progression-free survival, BFS2, and the other outcomes. These are the baseline characteristics for the BELIEF study. The result of this study with regard to primary outcomes, the alpelisib with in patients who received CDK4/6 inhibitor improved the progression-free survival at 6 months. As we can see here, the BFS or around 50% stay without progression at 6 months, compared to what has been reported in SOLAR. In SOLAR, one trial, they reported around 45% of patients who stayed without progression at 6 months. The median progression-free survival post CDK4/6 inhibitors by using this medication reached to 7.3 months. So the safety profile in this clinical trials were very similar to what has been reported with SOLAR-1, with again high incidence of hyperglycemia of 30% and skin rash again around 10%, and the area was around 6%. So what is the conclusion of this BELIEF study? So this is a confirmatory study and concluded that the use of alpelisib, both CDK4 inhibitors, improved the progression-free survival at 6 months and improved the BFS by almost 7 months with no new safety signals. The most common side effects, as I mentioned before, hyperglycemia and rash and diarrhea, were very similar to the SOLAR-1 safety profile outcomes. So in BELIEF study, there was a trend toward better outcomes in terms of managing those side effects, because the researcher learned from the treatment algorithm that was proposed in SOLAR-1 trial. So the last part of my presentation is about the toxicities management of alpelisib. The 3 most common side effects. I'll present the first one. The first side effects associated with the use of alpelisib was skin rash. So most of the patients in BELIEF study and in SOLAR were offered the antihistamine as a prophylactic for skin rashes and pruritus. As you can see from these 2 pie charts, this is without prophylaxis and this is with antihistamine prophylaxis. The incidence of grade 1 to grade 3 and 4 skin rash was significantly reduced. So in patients who did not receive the antihistamine, around around 46% developed rash if they did not receive the antihistamine. And if they received the antihistamine medications for prophylaxis, the skin rash was not seen in almost 3/4 of the patients. So the take-home message of this that most of the patients, patients should be offered the antihistamine prophylaxis. The second side effect is hyperglycemia. Hyperglycemia was very prevalent in those patients. Around 30% of the patients developed hyperglycemia. Patients with diabetes, with pre-diabetic condition were at higher risk of developing these side effects. So the management was to monitor the blood sugar closely and to offer them metformin. The third side effects was the diarrhea. We know how to manage diarrhea. Diarrhea was very prevalent. We can offer patients prophylactic use of doses of loperamide. And in case of the development of diarrhea, we should start loperamide higher doses. And if the patient persists to have diarrhea or severe diarrhea and admitted to your patients, they can be offered octreotide. This is the time course for alpelisib adverse effects. So the hyperglycemia and skin rash are seen in the first 2 weeks of treatment, and diarrhea can be seen at any time of the treatment course. So the key factors for prevention and managing the alpelisib toxicity, patient education is really crucial for those patients to manage and to prevent and minimize these common side effects of alpelisib. And I would like to conclude my presentation with this important slide from NCCN guidelines. This is the treatment algorithm for hormone-positive HER2 negative metastatic breast cancer. In case of advanced disease, the first line options are either aromatase inhibitor plus CDK4 and 6 inhibitor. Any CDK4 6 inhibitor can be offered with category 1 recommendation. The second option is to use, and this is the new recommendation, is to use fulvestrant with CDK4 and 6 inhibitors in the first line. And the other option is the single agent Faslodex, which was approved based on the Falcon study. The single agent fulvestrant showed a better progression-free survival compared to aromatase inhibitor. And in the second line setting, after the failure or after the progression of the first endocrine therapy, if your patient did not receive the CDK4 and 6 inhibitor, they must receive one of the CDK4 and 6 inhibitor with fulvestrant with category 1 recommendation. And for those patients with big 3CA mutated tumors, they can be offered alpelisib with fulvestrant with category 1 recommendations. So with this slide, I would like to conclude my presentation and listening.